And we're live. Hi, everyone. Welcome to Talking Life with Macy. I hope that you're tuning in. If you are, this is the best time. Please share this live stream with your friends, with your family, because we have an expert in the field of immunotherapy and lung cancer here with us today. It's very difficult to get his time. So please share this, as I believe this will benefit a lot of people out there. And of course, it's an avenue for you to ask questions. We want you to share this with as many people as possible. Once we have 15 people on today's live stream, we'll officially begin. So the counter is going up. I'll wait for more people to join today's live stream as we have 15 already. So it looks like a lot of people want to join today's live stream. So please, once again, share, like, engage with today's video because it's very difficult to get Dr. Tho's time, our special guest here today. Well, today our topic is on immunotherapy and the importance of screening for lung cancer. This is the second episode of a 3-part series. And last week we talked to Dr. Azrif from the president of the Malaysian Oncological Society on what lung cancer is and our lung health. And he did mention about immunotherapy, which is one of the latest forms of cancer treatment. And today we have Dr. Tho, who is an expert in immunotherapy and lung cancer, joining us. So I'm going to share with you a little bit more about what immunotherapy is before we begin to ask Dr. Tho questions. Of course, beforehand, I would like to ask you guys to let's not waste Dr. Tho's time. Like I said, it's so difficult to get his time. So start asking your questions now so we can pick it up towards the end rather than having a lot of questions at the end and we cannot pick up any questions. So back to immunotherapy. Immunotherapy is one of the most advanced forms of cancer treatment. Immunotherapy educates our immune system to recognize cancer cells and destroy it, as well as boost our immune cells to help eliminate cancer. It prolongs our lives and also improves the quality of lives. Now, I would like to introduce our special guest for today. He is a very busy clinical oncologist. I'm so glad to have him here today. Dr.Tho Lye Mun is a consultant clinical oncologist and the vice president of the Lung Cancer Network Malaysia. His passion and commitment to lung cancer has seen him lead many clinical studies in the field, particularly in immunotherapy. And he serves on numerous regional and international advisory bodies and guideline committees. So if you are a cancer patient, a cancer survivor, or you know anyone who has lung cancer currently or cancer, please ask them to join the show so that they can ask questions and we can talk extensively and learn more about lung cancer and the importance of screening and more about immunotherapy. So we have Dr. Tho Lye Mun. Thank you so much, Dr. Tho, for joining us.
Hi, Macy. Thank you so much for inviting me. Very kind of you. And also happy Deepavali to all your listeners who are celebrating.
Yes, happy Deepavali to all who are celebrating. I hope that you're enjoying the Festival of Lights. So Dr. Tho, I'm just going to jump into the questions because I believe that there are going to be many, many questions from the audience for you. So like I said, guys, time to ask your questions. Share this live stream right now so we can get people to come join and ask questions as well. We don't want to have a jam of questions at the end and we cannot pick up any questions. So let me begin with today's discussion. So Dr. Tho, from my understanding, you have vast experience in cancer treatment and even research, as I mentioned earlier. So could you share with us a little bit about your journey and why you wanted to be an oncologist?
Okay, I wasn't expecting that, but thanks for asking. So I've been an oncologist for, I think, 18 years. And my journey started when I guess I was in university and I felt oncology was a field that had changes all the time. So I didn't want to be in a field that there were no changes at all. So I find it very challenging. And both my parents were cancer sufferers and passed away eventually from cancer. So I suppose that motivated me as well to find new treatments and new cures.
Well, I'm glad that you are in the field so we can learn a lot from you and that you've helped with the advancement in cancer treatment. So tell us more about this Knowing Lung Cancer campaign embarked on by Lung Cancer Network Malaysia, MOS, and also National Cancer Society of Malaysia.
Yes, the Knowing Lung Cancer campaign has been a campaign that has been running since August and is culminating this month in November, Lung Cancer Awareness Month. It builds on our efforts last year to provide free low-dose CT scanning for patients who may be at risk of lung cancer. So if you fulfill and meet the criteria of 20 PAC years smoking between 40 to 75 years old, we have 8 participating hospitals in the Klang Valley, as well as Malacca, who are offering free low-dose CT scans. A low-dose CT scan is unlike a normal scan where there's no injections. It's done in 30 seconds in a single breath hold with less than a quarter of the normal radiation dose. And we know that picking up cancers early will allow you to cure them. The unfortunate thing in Malaysia is 93% of cancers are picked up in stage 3 and 4. And our goal and vision is to migrate all these patients to stage 1 and 2 by increased awareness, decreasing the stigma surrounding cancer and lung cancer in particular. That is a disease where people is caused by smoking, and so I think there's a lot of reticence where people are not putting themselves forward for checks and to have treatment. And I think also people feel that lung cancer is a deadly disease where there's no treatment. I think our discussion today will probably show your audience that that's no longer the case.
Thank you so much, Dr. Tho. So for those of you who are interested in the low-dose CT scan, as Dr. Tho mentioned, there are 8 participating hospitals, and I believe it's free, if I'm not mistaken, if you show a voucher. I'm going to attach the link on where the comment section is after today's talk, and you can pick up that voucher, bring it to the hospitals, the participating hospitals, and after that, just show it to them to get a free low-dose CT scan and a free consultation. So please take note of this. I'll put the link after this on Talking Live with Macy in the comment section. Thank you so much, Dr. Tho, for sharing. And Dr. Tho, I believe you'll be sharing some slides. So I'm going to dive into the questions on lung cancer. What are the earliest symptoms of lung cancer that are present?
Lung cancer may or may not have symptoms in the early stages. Generally speaking, patients present with a persistent cough, sometimes pain in the chest, shortness of breath. Sometimes they may cough up blood, or they may have weight loss, which is unintentional, non-dieting related. But of course, these symptoms may be nondescript, may be insidious, they may be confused with common respiratory illnesses or infections. And in patients who may have smoked, who have weak lungs, they may confuse it with their day-to-day symptoms. But of course, I think the differentiating factor is if you have these symptoms that persist despite treatment with antibiotics, the answer is not to have another course of antibiotics, is to really go and see a respiratory specialist, to get checked out, perhaps a scan, and move things forward.
I see. Okay, so how can patients detect lung cancer earlier?
The best way really is to do a low-dose CT or screening. Screening, the evidence for screening essentially comes from 2 huge international trials, one which was run in the US and one in Europe, where they took patients who had smoked at least 1 pack of cigarettes a day for at least 20 to 30 years and did just scans on them, whether they had symptoms or not. And these are the low-dose scans that we talked about. And they found cancers in these patients and early cancers, which led to them having successful surgery or radiotherapy, and they were cured. So I think the Malaysian authorities have also done a health technology assessment. They've looked at 27 studies involving over 300,000 patients and have come to the same conclusion that there is some benefit in targeting CT scans for patients who may be at risk of lung cancer. However, if you already have symptoms, then of course we would probably also do a chest X-ray or CT scan to make sure that we don't have an underlying lung cancer.
I see. Okay, that's good to note. And for those of you who would like to do screening or have not thought about it, this is one of the ways to detect lung cancer, as Dr. Tho mentioned. So let's jump into questions on immunotherapy. One of the latest forms of cancer treatment is immunotherapy. What is it in layman terms? I think people want to know about it, but they don't know really what it is.
I think you gave a very good description just now, Macy. It's I think just to echo your words, it's a treatment really that it's unlike other treatments, for example, radiotherapy, chemotherapy, targeted therapy. These are treatments that are designed to find the cancer cells and kill them. However, immunotherapy is different. When we give you immunotherapy, sometimes the drug itself doesn't kill the cancer cells, but it boosts your immune system such that your immune system is now able to recognize and kill the cancer cells. There are a few different types of immunotherapy out there. The most, perhaps the one that your viewers may have heard of is vaccine therapy. And there's a big write-up about COVID vaccines, mRNA virus. So what is vaccine therapy? Vaccine therapy is giving a patient an attenuated form of the cell or cancer cell, part of the cancer cell, so that your immune system can build antibodies. This approach has been used for many years in lung cancer, but has met with very little success. So vaccine therapy is out. Another type of therapy is T-cell therapy or cellular therapy. So that's removing some of the T cells or the immune cells from a patient's body, enhancing it, boosting it, changing it, and then delivering it back to the patient for the cells to find the cancer cells and kill them. Again, this approach has not been very successful. Another approach that, of course, a lot of patients do explore by themselves is natural supplement therapy, exercise, diet, and so forth. Unfortunately, it doesn't seem to have yield, again, the spectacular results that we need in order to overcome the cancer. And unfortunately, many exotic animals have suffered in the process, including tigers and bears and porcupines. So, which leads me to the kind of immunotherapy that we use day to day in clinics now. So it stems from the work of James Allison and Tasuku Honjo, who won the Nobel Prize in 2018. So what they found was that cancer cells have an accelerator and brake system that it influences our immune system. So the immune system actually by default, so the natural state of our immune system is to recognize these cells as foreigners and attach to them and kill them. However, these cancer cells then are able to put up a camouflage mechanism to disguise themselves, and they sometimes affect our immune system to depress our immune system. So sometimes you may hear of patients develop shingles, the vesicles that come out, or they may get infections more easily. So it's not the chemotherapy. Actually, the cancer cells can depress a patient's immune system. So what we've developed is drugs called PD-1 and PD-L1 inhibitors, which actually attach to the cancer cells and just removes this camouflage mechanism. It unmasks the cancer cells. It's like, being at a masquerade ball, everyone's wearing a mask. No one can recognize each other. So PD-1, PD-L1 inhibitors removes the mask, and the good guys can now recognize the bad guys and go to work. So hope that's clear.
I see. So, from my understanding of immunotherapy, because I've learned this 2 years ago in an international conference and also a couple of conferences here in Malaysia about immunotherapy and like what you mentioned, using our immune system to fight the cancer cells. I mean, that is what I understand from layman perspective. So, Dr. Tho, I believe you have some slides you would like to share. Will you be sharing it during now? I mean, now or in the next few questions that I have for you?
If you have time, yes, I could share it now actually.
Before that, is it available in Malaysia? I think people would want to know, is immunotherapy available in Malaysia and where is it available?
It's certainly available. We have been using these drugs routinely for the last 5 years, and we've built up quite a large experience of using these drugs. Some of patients that I started treating with immunotherapy 5 years ago are still alive right now with stage 4 lung cancer. So that's fantastic news. The availability varies between which setting you're being treated in. It may not be so readily available in the government sector because it is quite an expensive treatment. One of the ways to access immunotherapy is via clinical trials. So where these new drugs are being brought onto the market, and they still need to undergo a little bit more testing before they receive approval. So these trials are available in Malaysia and in the government sector. So this may be one avenue for patients to access the drugs. They are also running in private sector, of course. So I'm running clinical trials as well.
All right, that's good to hear. So, for those of you who are interested to participate in any of these clinical trials, you can probably ask Dr. Tho as well about this. All right, Dr. Tho, could you share with us the slides that you have? So, Dr. Tho will be sharing some slides with us. So, do let us know if you can see it or not once he has flashed them up. I see.
So just to plug the campaign for low dose CT scan, these are the hospitals. So immunotherapy, as you know, has been widely covered by the media. This slide just illustrates graphically where the cancer cell is the yellow cell being attacked by our innate T cells. T cells are the ones that attach to the cancer cells and recognize them and eliminate them. So as you may well have heard, the traditional 5-year survival for stage 4 lung cancer patients is less than 5%, around about the 1 to 2% mark. But with immunotherapy, the latest data shows a 5-year survival of 32%. And we have now trials combining immunotherapy with chemotherapy and radiotherapy, and we do expect the results to be even better. So watch this space. So this is just an illustration of how the camouflage system is affected by the cancer cells. So cancer cells essentially are like a Trojan horse. So they slip in under the radar, but within them are very, very serious consequences. So just to share a patient I treated with a combination of chemotherapy and immunotherapy. This patient had a squamous cell carcinoma, which is traditionally very, very difficult to treat, and patients do not survive beyond 1 to 2 years. The patient had a huge liver metastases, and the blood test showed very abnormal liver function. The liver was working extremely hard, and the patient also had liver metastases. But after treatment, you can see the patient had a very, very excellent result. This is a PD-L1 inhibitor, and this is a patient who had not a very big tumor in the lung, but it was so central. It was attached to the trachea and also the carina. So a surgical operation was not possible. Even if you did a surgical operation, it would have been a huge operation requiring the removal of the whole lung, and the patient would have been quite severely affected by that. This was in August 2017. So we use a very new method, a combination of radiotherapy, chemotherapy, and immunotherapy to treat this patient. And I'm pleased to say it resolved completely and is still well until now.
Wow.
The patient is a mechanic from Sabah who came all the way to see me, And both this patient and the patient previously, I'm glad to say, received patient were able to benefit from a patient access program very kindly given by our pharmaceutical companies that produce the two drugs, PD-L1 inhibitors. Okay, I think I'll just stop sharing that. Thank you.
Okay, thanks a lot, Dr. To. Now, the thing is, I think many people want to know, is immunotherapy suitable for all lung cancer patients?
It's a great question. What happens when a patient comes to see us, assuming they are stage 3 and 4, we do molecular testing. That means we take a sample of the tissue from a biopsy. Normally the biopsy is done inserting a needle through the lung via some local anesthetic, removing few small pieces of the tissue. From that tissue, we can actually tell a lot. You know, that's our compass, that's our GPS, that's our ways for you for the next however many years you need your treatment. So that tells us what kind of treatment we need to give you. About half the patients in Malaysia will be suitable for targeted therapy. So those patients are not suitable for immunotherapy. So they should have a drug specifically designed to that particular gene, or that particular mutation. The rest are suitable for immunotherapy. So about half of patients, by right, should get immunotherapy either on its own or immunotherapy in combination with radiotherapy or chemotherapy.
I see. Okay, I really like your case studies earlier, and I'm very glad that your patients are doing well now. And I've heard that immunotherapy prolongs lives of lung cancer patients, and quality of life is also maintained. So is that true?
Yes, the studies, I'll answer the second question first. A lot of the clinical studies have consistently shown that the quality of life of patients is better on immunotherapy compared to chemotherapy. So this is by objective measurements. You know, we ask the patients, how do you feel? Are you tired? Do you have diarrhea? Do you have vomiting, etc.? So the scores consistently plumb in favor of immunotherapy. It doesn't mean immunotherapy has no side effects. We can discuss that if there's time. Your second question is what, in terms of survival, immunotherapy is very, very unique. It's unlike any other treatment that we've had in our armamentarium. So a lot of the treatments that we have, for example, chemotherapy, targeted therapy, we give the treatment, but we cannot stop. It has to continue. The moment we stop, the tumor will grow again. So even if we stop, we know that the tumor will progress at some point and develop resistance. The interesting thing about immunotherapy is that in a very small proportion of patients, let's say 10 to 15%, they get a fantastic long-term benefit from the treatment, even though the treatment has been stopped even many years ago. So somehow the immune system has been changed, has been primed to recognize cancer cells as soon as they emerge, and they deal with the cancer cells. And the patient can actually go on for many years without treatment and be entirely well. We are hesitant to call it a cure, but we know that some patients are even surviving 5 to 10 years with stage 4 disease. But I stress again, this is not everyone. This is the minority of patients, but it happens. I think it's very similar to case reports that we've seen occasionally that come up in the literature, that people their tumors spontaneously regress. It's called spontaneous regression. They just disappear, and that's the immune system kicking in. That happens very rarely without help or aid or benefit, or without treatment, immunotherapy treatment, but it happens on its own spontaneously sometimes.
I see. Well, thank you so much for all of you sharing all of your data. I think that has been very beneficial to understanding more about immunotherapy and the treatment that it offers to patients out there. So I believe I'm going to start picking up questions. Maybe during those questions, if there are pointers in your slides you want to share, please feel free, Dr. Tho. So I'm going to pick up the questions that you've put in already. So we'll start off with Regina Yong. She says, "Hi, doctor. She's a stage 3A NSCLC with EGFR plus. She has done a lobectomy, 4 times chemo, 20 times radio, and she has completed standard care on May 20th. So her latest PET is clear. Should she start off with targeted or immunotherapy, or should she wait for a relapse?"
Okay, thanks for your question, Regina. So the answer to that is yes. There is a role for targeted therapy in your situation. It comes from a trial called AURA, which was released this year. The study randomized, or what we call divided patients. Half of them received nothing, and half of them received a drug called osimertinib. This is an AURA study. And clearly, the patients who received 3 years of osimertinib had a fantastically reduced risk of cancer recurrence. So it's certainly something to discuss with your oncologist. And while it does depend on when you finished your chemotherapy, we tend to want to start the osimertinib as soon as possible after chemotherapy.
Okay, I hope that answered your question, Regina, and I hope that you will get better soon. So the next question is from Yogimbi. What would be the advantages of immunotherapy compared with the more conventional chemotherapy, and is immunotherapy suitable for all cancers?
Thanks, Madam Ms. Yo. It's not suitable for all cancers. In fact, it may backfire on you if you have what we call an activating mutation or oncogene-driven tumor. So it's very important to do the molecular testing upfront. That means when the patient, even before you decide what treatment to do, you need this molecular test at hand. I think you have another session on targeted therapy. The other speaker may develop this idea further, but in general, you need to test for at least 3 genes, which is called EGFR, ALK, and ROS1. If you have any of these 3 genes, you need targeted therapy. If you are given immunotherapy, if you have these 3 genes, in fact, it may make the tumor more aggressive and grow even faster. That's the worst case scenario. The best case scenario, it may not work very well. So it only works if you do not have, it only works for a particular profile of patients.
Okay, so she asked as well, what is the success rate of immunotherapy?
So the latest data we have to hand is the 5-year survival of 32% with patients given immunotherapy upfront. That means that the moment you come to see me with this diagnosis, we give you immunotherapy and we follow you up. So the 5-year survival is 32% compared with what we had historically in this group, which is less than 5%, 1 to 2%. So that's more than 10 times higher.
That's amazing statistics, huge improvement. And the next question is Chong Yan Wan from Chong Yan Wan. She says, good afternoon. Is immunotherapy suitable for lung cancer patients with PDL111HC, tumor proportion score 0%? And is it suitable for early stage lung cancer?
Okay, so thanks, Ms. Chong. PDL1, we haven't discussed that yet, but along with EGFR, ALK, ROS1, we also check the PDL1 status of the tumor if we are considering immunotherapy. PDL1 actually is the target for which our immunotherapy drug attaches to. So it's basically giving us an estimate of how likely or how effective our treatment will be. So if you have 100% score on your tumor, for example, means your tumor is full of that target, full of the bullseye that we need to shoot the arrow against. But if it's 1%, means it's very low. In a patient who has 0%, immunotherapy can still be used. It is not a complete exclusion factor, but generally speaking, we would use immunotherapy in combination with chemotherapy. So the chemotherapy and immunotherapy synergize; they work together like in an orchestra. The sum of the parts is greater than the individual instrument. So it's the same thing with cancer treatment. We sum up the immunotherapy, we synergize the immunotherapy and chemotherapy, and we actually get better results than if we didn't use immunotherapy. The second question was...
Is it suitable for early lung cancer?
Early lung cancer, excellent question. So if it's suitable in late stage lung cancer, you bet your bottom dollar that drug companies will try it in early stage lung cancer, or not just drug companies, us as clinicians, we want to get maximum benefit from the drug that we have. The answer is yes, it is beneficial. For example, they've shown in some early preliminary studies that if you give immunotherapy before you go for an operation, after the operation, the tumor that comes out of the patient has a very high death rate. So that means you're killing the tumor even before you operate. So there are certain advantages to that. One, you can give immunotherapy immediately. An operation, there's a little bit of preparation, there may be a bit of delay, we have to get you optimized. We can start with immunotherapy first. The second benefit is we can start to hit those small cells that may have broken off from the mothership, the satellites that are trying to fly about the rest of your body and cause problems. We can deal with them first, and the big mothership we can deal with surgery, a couple of weeks down the line. Having said that, this is not standard of care yet. That means it hasn't made it into routine practice, but watch this space. I'm pretty sure in the next few years, we will be seeing the use of immunotherapy upfront in early stage lung cancers.
I see. Thanks, Dr. Tho, for that detailed explanation. We hope that answered your question, Chong Yuan Wan. Next question is from Ms. Charmaine Yo. For initial stages of a tumor 2.6 centimeters, the patient does not feel any breathing difficulties. Is surgery enough without chemo and radio?
So the answer is the patient will need some sort of definitive treatment. That means treatment to really get rid of the tumor once and for all. So that is our goal in someone with just a 2.6 centimeter tumor. Now, whenever we consider what to do, we have to stage the patient very carefully. That means we have to make sure that that 2.6 centimeter tumor has not sent off cells elsewhere in the body, because we will need to deal with those cells as well. And what the patient really needs is a PET-CT scan to start with, and also an MRI scan of the brain. About 30 to 40% of lung cancers may spread to the brain, and it's an area that cannot be detected on a normal PET scan or a normal CT scan. You need an MRI scan of the brain. Now, 2.6 centimeters is what we classify as an early stage. Probably the patient will not need chemotherapy following surgery. However, we don't just base the decision on the size of the tumor. We have to take that pathology specimen and check to see whether blood vessels have gone into the tumor, whether the tumor has gone into the blood vessels. So that may be a risk factor for the cells going to other parts of the body. We need to know whether that 2.6 centimeter tumor is touching the surface of the lung, the pleura, or what we call the pleura. Our lung has a lining. If it's already touching the lining of the lung, that may be a conduit for it to spread elsewhere, and that patient may need chemotherapy. So many factors. What you need to show the oncologist is the final pathology report.
I agree on that. Thanks a lot, Dr. Tho, for answering that question. Now, next is Miss Serene Fong. She's a stage 4 melanoma patient. She started Keytruda in a government hospital, and she was advised to take 1 year worth of treatment. Do you think 1 year is enough? Wow, that's very so I don't know.
Okay, so so for those trials involving that particular drug, the trials went on for 2 years. So actually, the recommended time or duration of therapy is 2 years, not 1 year. Having said that, if a patient gets a complete response, that means on a scan, we don't find any more evidence of the tumor macroscopically, at least visually, then you may continue another 6 months and then stop. So that is an option as well. It really depends on the response, but generally it's a 2-year treatment.
Okay. So that's a recommended duration, right, Dr. Tho?
Yes.
All right.
It
We have a lot of
differs from
questions.
drug to drug. It differs from drug to drug. So other drugs, for example, atezolizumab, require treatment, ongoing treatment till progression. So there are differences in the recommendations for each drug.
All right. Thanks a lot. And the next question is from Miss Dorothy Ng. Her husband has liver cancer. Can immunotherapy work on liver cancer?
In the month of November, we need to get more male listeners on your program, I think.
There are male listeners. The next few questions from males. Don't worry. That's why I think we have a lot of questions today.
Come on, man. Make me proud. Okay. So liver cancer, definitely there is a role for immunotherapy in liver cancer. So there's a trial using atezolizumab plus bevacizumab, which has shown very promising survival advantage over conventional use of sorafenib or targeted therapy. We also use it in the second line setting. So for liver cancer, answer is yes.
All right. The next question is from Tang Man Hoi. Hi, Tang Man Hoi. It's good seeing you again. He asks whether lung cancer can be detected through cancer markers.
So the risk of relying solely on cancer markers is that the traditional cancer markers, things like CEA, CA153, tend only to go up once the cancer is quite advanced, once the tumor is quite big or it's spread to other parts of the bodies. So this is what we call a false negative. That means you take the blood, you go to a hospital. There are many hospitals that talk about screening packages with cancer markers. It comes back normal, and it gives you a false sense of reassurance because these markers tend to go up only in later stage disease. There are exceptions. Sometimes when you have a small tumor, you may have very high cancer markers, and you may be lucky and pick it up. So relying solely on cancer markers may not be the best strategy. Having said that, the Lung Cancer Network of Malaysia is working with a company that has a new form of cancer markers, which are useful in conjunction with low-dose CT scans. So this is very exciting. It's very new, and it's a new generation of markers, which we hope, as the Lung Cancer Network, will hopefully we'll test it, we'll make sure it works well, and hopefully let the public know about this.
I agree with you. I would like to add that I actually went for cancer tumor marker test. Before I found out I had cancer, it was just a routine test. Nothing was detected, but I actually had cancer already. So I agree with you, Dr. Tho, on this, that maybe, tumor markers might have a false negative. I believe mine was a false negative. So hope that answered your question. The next one is Mr. Edwin Aoyong. Who is more at risk to get lung cancer, he asks?
So by far, the biggest risk factor is still smoking. So direct inhalation of these toxins that cause DNA mutations in your blood. So a smoker has about 20 to 25 times higher risk of cancer compared to a non-smoker, and and about 25% of Malaysians smoke. That's the most recent data.
No.
But we see about 20% to 30% of our patients, especially younger females who have never smoked, developing cancer more and more. So that's increasing, an increasing trend in the Asian community. So by no means smoking is the only risk factor. So with smoking, of course, I forgot to mention that it's not just direct smoking, first person inhalation. There's also second-hand smoke, and there's also smoke transmitted through washing clothes of someone who smoked, for example. So the smoking habit actually affects more than just the primary person. So of course, at Lung Cancer Network, we have supported and continue to support the government's efforts to ban smoking in public places and restaurants, and continue to advocate and support the tobacco tax.
I agree with you. Continue to ban smoking in public places. Uh, and the next question is from Mr. Gary Lau. Can immunotherapy be used to treat prostate cancer?
Answer is yes. Immunotherapy can be used, but it's shown to be useful only if you have particular type of genetics. So microsatellite instability, for example, if you do find that in the prostate cells, definitely immunotherapy is a fantastic option. But by and large, the results have not been as promising as in lung cancer or melanoma. So prostate remains slightly behind in terms of our expected results.
Okay, thank you for sharing that. The next question is from Mr. Kevin Pang. In his CT scan, radiologist found two very small nodules of 2 millimeters. Should he be concerned? And the oncologists do not seem to worry, as they would like him to go through his T1 bladder tumor first.
So 2 millimeter dots in the lung are very small by general standards. If you're worried that you have metastases, that means cells from the bladder that have gone to the lung. It's what we call too early to characterize. Unfortunately, there are some things which we really are not able to say at the moment. So most likely they will advise you to get a repeat scan in a few months to see if these spots grow. At 2 millimeters, they're too small to biopsy. That means it's very difficult to find if you stick needle in to take some of the cells out to really make sure whether it's cancer or not.
Okay.
A PET scan as well would not be able to tell you because they're too small to light up on the PET scan. And if you have a history of smoking, then these spots could well be lung damage from previous smoking, or if you've had previous infections of the lung, tuberculosis. Again, those sorts of infections can produce long-term scars, which may be seen as dots. We do see patients who have had exposure to certain environmental toxins. For example, their workplace has a lot of smoke and a lot of chemicals, fumes, and they also present with dots in the lung. So I think your oncologist or your respiratory physicians needs to sit down with you and really work out what it could be and then monitor it very carefully.
I see. Okay. To all of you watching, I'm going to take about 2 more questions because I believe Dr. Tho is very busy. So I'll pick up. This one is a follow-up question, Dr. Tho. She was asking you, actually, Miss Charmaine said you were mentioning about a final pathologist report earlier. So she asked whether this means the report from the biopsy.
No, the report from the surgery.
I see.
So once the tumor has been removed, then they will do a very thorough examination. and produce a pathology report.
All right. Thank you so much. I guess I'll take the next question, the second last question from Teo Chong. He works in the charcoal industry for a long term already, and can it cause lung cancer? Although he's a non-smoker.
So unfortunately I'm not familiar with maybe the different types of workplace or environmental exposure risk. The doctor that is trained to assess is what we call an occupational physician. So that means they actually specialize in looking at workplace and assessing the health risks of various exposures or chemicals or conditions at the workplace. But in general, if you're working in the charcoal industry, I would imagine that would involve quite a lot of fumes. So harvesting charcoal, sometimes burning it in order to prepare the charcoal for sale and as such. So definitely there will be some effects on the lung. I would imagine. I may be wrong. I have to qualify. I don't deal with occupational health matters. If you're worried, if you have a history of smoking, in addition, then I think come and see us. Take advantage of the screening this month.
Yeah. And one last question would be from William. He asks, at what age should they start lung cancer screening, and is it once a year?
So the trials that looked at lung cancer screening was just a one-off. That means it's not like breast cancer screening or colorectal screening. It's just a one-off at one point of time. If you have a clear scan, there's no recommendation to carry on screening, but there's a big recommendation to stop smoking. So actually the trials have shown that the actual act of the patient going for screening was a trigger for them to stop smoking in about 30 to 40% of people who went for screening, which is a good thing.
Yeah, that's really good. All right. So yeah, I mean, time's up for you. You're so busy. Thank you so much, Dr. Tho, for joining us today on Talking Live with Maisie. And thank you so much. Thank you all for your questions. I know there are more questions from all of you. I'm sorry that we couldn't answer them. But this is the second episode of the lung cancer series. We have one more episode next week talking about targeted therapy and the importance of screening once again on lung cancer. Do join us next week with Dr. Tan. And more importantly, thank you so much, Dr. Tho, for such an informative session and sharing more about the statistics and being so clear about everything.
Thanks, Maisie. It was a pleasure to be here.
Thank you so much. Everyone says thank you as well from the comments, it looks like. And again, to reiterate, this is the Knowing Lung Cancer campaign. There's a free low-dose CT scan given and also a free lung consultation at any of the 8 hospitals listed. I will be sharing the link with you at the comment section after this. So stay tuned for that. And I think Dr. Tho also mentioned about it earlier when he about this free low-dose CT scan. So thank you once again, Dr. Tho. Please do visit him if you have further questions at Beacon Hospital. He is there as well as, I believe, right? Beacon Hospital, Dr. Tho.
Yes, Beacon, yeah. Beacon,
okay,
Beacon.
All right, so Beacon Hospital. So please, if you have further questions, do visit him at Beacon Hospital. Thank you so much once again. And do find out more about the Knowing Lung Cancer campaign, everyone. Thank you all and have a great Sunday. Join us next week again at 3:30 p.m. on Talking Live with Maisie for the final episode of the Lung Cancer series. Okay, bye everyone. Thanks, Dr. Tho.
Bye.
Thank you, everyone. Dr. Tho is from Beacon Hospital, Jerry. Okay, thank you all. Bye.